So I'm Dr. Adrienne Whitt, and I'm from the University of Kentucky. I'm an assistant professor in the College of Medicine, Department of Psychiatry. And I'm also the associate director of the Center on Trauma in Children. Has anyone heard of the Center on Trauma in Children here at UK? Okay, maybe a few of you have. Maybe a few of you have heard of some of our programs that we have, which I'm going to tell you about in just a moment. I may refer to the center as CTAC or the center because it's kind of a mouthful. I'll be talking about it a little bit. Steve had asked me to tell you a little bit about what we're doing to address the needs of children who've experienced trauma, which is what we're going to talk about today. I will also add that, another hat that I wear, I guess, is that I work in-house at DCBS, usually about 1 day a week as a mental health consultant, mainly in the Southern Bluegrass region, but I do kind of hop around throughout the state because I work with the child welfare programs as well. So lots of little acronyms, DCBS, that's our child welfare system. I used to work with this older gentleman, one of the psychiatrists in our department, and he hated acronyms. And he declared that one meeting we were going to not use any, no acronyms for the whole meeting. And so we had to say out every single thing. If we were talking about DCBS, we'd have to be the Department for Community-Based Services and Center on Trauma. I'm like, it took twice as long. And I think even he, by the end of it, was like, okay, let's use some acronyms. But if I use something and it's like, what is she talking about? Just tell me and I will promise I will explain myself. So a little bit about child trauma and what we do and why we do it. I don't know, I'm a social worker by discipline. And I started out, bless you, working with older adults in the homeless population. That was my first gig, and I loved it. It was awesome, but it was also hard, because it was difficult to help these folks make dramatic changes or sustain them really at that latter stage of life. And I understand that now, being someone who's more in the midlife stage of life. I can still make change, but it's harder for me, even to make small changes. You might have noticed this in other older people like myself, but with kids, change is the only constant, right? They're still growing, their brains are still developing. Change comes much more easily. And I had one internship, I guess my last internship in graduate school, and I started working with kids and I saw just the wealth of possibilities, and especially to kind of interrupt that cycle, that kind of cascade effect that we see sometimes when people have early adversity or trauma in their lives, how just one bad thing leads to another, right? So we're going to talk about that a little bit, how child trauma impacts not just kids in the kind of immediate sense, but also if we don't address it, it can impact adults. And, that program that I mentioned that I work with in DCBS, it's called Breaking the Cycle. And I see that with my families that I work with so much, we want to break the cycle because it's not just that cascade effect that happens in one life. If we don't do anything to mitigate trauma and the impact on people, it can go on and be passed on to the next generation. Every single adult. I'm not exaggerating, and I like to tell a good story. I'm Appalachian, so watch me if I do exaggerate. I'm sorry, it's in my nature a little bit, but I'm not exaggerating. Every parent that I work with, and I work with the high-risk child welfare population, they've all experienced trauma themselves significantly, not a little bit, a lot bit. So no one probably did enough to address what they needed and to kind of help them recover and heal from that. And now we're seeing it play out with other generations. And sadly, I'm old enough now, I've been doing this work for about 25 years. I'm seeing some of my former patients' kids, and that just breaks my heart. Because we do know how to help. We actually do, and I'm going to talk to you about that today. So I'll get off my soapbox for a minute. But as you can see, we're pretty passionate about addressing the incidence and impacts of childhood trauma. And my colleague and our leader, Jenny Sprang, I don't know if any of you have had a chance to meet her. She's the executive director of our center, and she and a few other folks from the College of Medicine and College of Social Work started these programs. We're getting ready to celebrate our 25th year. I'm so excited. I've been there since the beginning, and when I say that, I'm like, oh my gosh, how did 25 years go by? And y'all know social work years are literally like dog years, so I'm at least 250 years old. So if I forget something or I ramble on, you gotta forgive me. But so over the last 25 years, we really expanded our reach quite a bit. We started with the CATS program, which is one of our clinical practices labs that you see down there. So we have we're under the College of Medicine, and then we have a kind of independently funded, with a little bit of support from the College of Medicine, Center on Trauma in Children. And we have three main areas of initiatives: clinical practice labs, so clinical service centers, training and education projects, and then research and dissemination projects. I'm the associate director, so I'm lucky enough I get to work on all of these things. Some more than others, certainly. The CATS program is our child welfare court. We have multidisciplinary teams of court-appointed evaluators that work with the most high-risk families across the state. And we do these trauma-informed comprehensive assessment plans and try to see if there's ways we can reduce risk in these families and safely reunify them. Or if not, then develop plans to secure permanency for children in other places. Our teams go to court, we testify, we do all those things. I know you all heard from Dr. Howard earlier, and her team does a lot of, we work kind of in conjunction with them. They're kind of substantiating what did or didn't happen in these high-risk cases. And then we're kind of doing assessments and talking about, can we fix this? Can we not? What's the best thing for the child? So we see a lot of trauma impacted kids and their caregivers, who many of them were also trauma impacted kids, and not that long ago, because a lot of them are pretty young. We also have the CADI program, which is the Child and Adolescent Trauma Treatment Initiative, which also serves the whole state of Kentucky. We do get a lot of our families, obviously more from the southern bluegrass region, but we see families from far western Kentucky, Eastern Kentucky. Now with the better expanded use of telemedicine, we're providing a lot more treatment services around the state. CATS has always served many court-involved families from around the state. But here you can see a variety of the other things that we work on to address child trauma. Lots of systems transformation, like education projects. We try to work with pretty much, I think we work with all the child serving systems throughout the state now. And many national and international partners too. Just trying to help all these, like education systems, juvenile justice systems, child welfare, to help them be trauma informed and to utilize that perspective when necessary. So we feel like, it's kind of our job as educators too, to share what we're finding in, of course, our research work. So, a big part of my time and Jenny's time, and we have a team, I think, of 6 of us now who are clinical researchers who are trying to develop more technologies to better treat childhood trauma and its effects and reduce the incidence of child maltreatment specifically. That's something I'm very interested in personally. So that's a little bit about what we do. You can check us out on our website, which I'll give you again at the end of the presentation, but it's pretty simple: uky.edu/CTAC, Center on Trauma in Children. And there's all the information you'd want in there and more, I feel confident. I will say one last quickie thing about what we do. We have a lot of great funders and partners. I would say, certainly DCBS has always been an amazing partner for us. Our child welfare system here is extremely invested in being as trauma informed as possible. I mean, if you don't get to work with other systems outside of the state of Kentucky, you may not realize how progressive some of the things they're doing are in that regard. Same with our departments of education, juvenile justice. I mean, I'm really seeing a huge movement to embracing addressing child trauma. And it's impressive, especially when I get to hear what other states are doing. We also are a part of the National Child Traumatic Stress Network, which I do want to plug that website, and I don't think I put it at the end of my presentation, but it's nctsn.org if you want to know anything there is to know about child traumatic stress. They're a great clearinghouse. Your federal government dollars and tax dollars pay for all of that. It's your resource, and they're great no matter what discipline or field or area you work in. They have resources for you if you're in education or public health or whatever the case may be. But I will just say a few things about the impact of trauma, just so that we're all on the same page, and then about what our research and our work over the years tells us that kids need to recover from trauma and why it's important, I guess. So, there's a variety of different kinds of trauma that children can experience. It's not just child abuse, although I will say, being a trauma therapist and clinician for over 25 years, it's mostly child abuse, but there's still a lot of other things, unfortunately, that our kiddos do experience. And if you look at this list, you may see that there is something distinct about this list, and I will just point this out. Sometimes people use the term trauma a little loosely, and by that they mean something stressful. Like, I think I'm even guilty of this. I think once I got a really bad haircut. Like, I'm not exaggerating. It was the worst haircut I've ever got in my life. And I think I may have told people I was traumatized by it and I never wanted to get another haircut again. But I was just being ridiculous, right? Like, I wasn't actually traumatized by this bad haircut, although it was like almost that bad. It really was. It took years to grow out. I'm not kidding. But really what a trauma is not just an extreme stressor. And that's what people are saying when they say that, like, oh, that divorce, the divorce was traumatic for our family. Divorce is not technically a trauma, although sometimes it can be paired with trauma, and then it is. But traumatic events are things that are either life-threatening or potentially life-threatening. They feel like you feel like you could be harmed to the point of death or seriously physically injured by what's going on. And the reason that distinction is made is because it does create this physiological response in you that's more than just worrying about something. It's that fight or flight mechanism gets activated. You feel it. You feel the hormones rush through your body, preparing you to respond to that threat. It's a threat to your physical integrity. And of course, it's also very just emotionally stressful or emotionally laden too, but there's that extra element. So if you look at all these things, having these things directly happening to you, witnessing these things, or even hearing about these things happening in your home or to your loved ones, all could have that effect on you. Like, you might then fear for your own safety. So these are traumas. Trauma is a little different than some of the extreme stressors that get kind of thrown in there. And of the kids that we see at the center, and this is in both of our clinics, which again, this is not like a random sample. I'm not an epidemiologist, although I read a lot of y'all's work. There might be some of you in this room. But of the kids that we see who are presenting themselves either to the child welfare system in a significant way, almost all the kids that we see are in foster care or have been removed. So this is not just like an occasional call for neglect or something. To the point of going to foster care, those kids have experienced, on average, 4 types of trauma. And I don't mean they experienced 4 traumatic events. I mean they experienced 4 categories of trauma. So look at that top list. They've experienced at least one, usually repeated experiences of 4 different things on that list. Now, that's pretty significant, right? So again, these are kids in foster care. These are kids in residential care. These are kids in juvenile justice. Kids who are presenting for trauma treatment. This statistic holds across studies. Our sample looks like national samples, international samples. This is commonly reported stat. These kids have experienced at least 4 types of trauma: chronic, complex, early in life, at the hands of caregivers. So serious stuff that puts them very much at risk for lots of problems if not dealt with appropriately. So let's talk for a moment about the general population of kids, a population that I often feel like I don't know that much about, which is kind of weird because I have a couple of kids. I've also spent my whole life thinking about kids, but I'm always working with the clinical population, right? So when I see just like, your regular kids in the community, I'm always like, look at these amazing, bright and brilliant kids, because they have so much less stress than the kids that I'm usually working with. But let's just say even average kids in the community, By the time that they reach age 16, and again, this is not my study, but this has been repeated across studies, about a quarter of them will have experienced at least one significant traumatic event. So I think that child trauma is something that if you're concerned about kids, you're developing programs for kids, it's something to think about, even if you're concerned about adults, because by the time you reach the age of 40, almost everybody's experienced at least one significant trauma by 40. It's like 85%, but some studies will estimate it higher, more like 95%. So unfortunately, while traumatic events are something beyond the range of normal experiences, they're also part of the human experience, right? Like, it should not be something that you experience regularly. It should likely overwhelm your capacity to cope, which is another definition of trauma. But it's something that you are likely to encounter at some point. And that's okay, because guess what? Human beings are amazing. We're extremely resilient. There's certain things we need to be resilient and to recover from things. But what is not okay is when it happens again and again and nobody comes to intervene. And that's what happens a lot of times for children. And that's why we see children who are very affected by the trauma that they experience. Yes.
Just a quick question.
Yeah.
How do you define medical trauma? Would that be having a life-threatening disease, or what exactly?
Yes.
I've not encountered that before, so I'm curious.
Well, I'm really glad that you brought that up, because medical trauma is probably the most overlooked, under-addressed form of trauma. I think we can all agree that if, God forbid, you encounter a child who's been sexually abused, you're probably going to be like, okay, that must have been traumatic, right? Or physically abused, or witnessed a shooting in their neighborhood or something like that. Medical trauma happens to kids all the time. It happens to adults all the time. And nobody's ever, I'm not going to say nobody ever, I would say by and large, we miss lots of opportunities to check in with people and say, hey, how are you feeling about this? Yes, we're talking about any medical event that feels life-threatening to a kid, usually significant things. Probably most kids are not traumatized by breaking their arm, but our kids at the Kentucky Children's Hospital who are there to be treated for cancer, absolutely, that's a traumatic stressor. And our hospital does a good job of trying to address that too. Transplant patients, oh my gosh, how complicated is that? Yeah, things of that nature. Anything that, if you feel like you might not make it out of a situation, then yeah, there's a lot, and it's really largely under-addressed, and I'm not trying to harsh on my medical colleagues, because I love them and I learn from them every day. And we on the mental health side are guilty of this just as much, maybe more, but there's not this like imaginary line right here that disconnects your brain from the rest of your body and like, oh, these are psychological conditions and these are medical conditions. Like, guess what? It's all related. So the thing I love about trauma, that's a terrible thing to say. I don't love anything about trauma. The thing I find fascinating about studying trauma is and PTSD in particular, is the one time where we're really good at recognizing there is this brain-body connection. Your fight or flight gets activated. That fuels your distress. Your distress fuels your hormone release in your body that makes you more likely to have, high blood pressure and things of that nature if not addressed. So I find that really interesting, and I think we have a lot to learn from PTSD because of it, because we often separate the two too much. I'll say one last nerdy thing. Well, no, I won't. I'll say many more nerdy things, but this one's extra nerdy. But a little fun fact for trivia night. And maybe a lot of y'all know this, but PTSD is one of the newer diagnoses that we acknowledge. We really didn't even talk about it until the 80s when our Vietnam vets started coming back. Again, that military connection. We learned a lot about what trauma looks like from them. And it actually started out, it was called combat fatigue in the 80s. And it was, like a solid, I think 10 years later before we even started calling it PTSD. I mean, it was just combat fatigue forever. But if it weren't for our vets being brave enough to, again, like share their distress with us and help us understand it, we wouldn't know what PTSD was and we wouldn't be able to treat these kids this way. And really the pioneers in the treatments of trauma for adults, and then, it moved to understanding trauma in kids, that would be the VA. The VAs are kind of the leaders in all the PTSD research. So here's some of the domains of impairment we see in children who've been impacted by trauma. And here I'm talking like proximally, like in childhood, we see lots of disrupted attachments. Many of them have experienced trauma at the hands of caregivers. So it's difficult even once they're with new, safe caregivers to feel like they can trust and have good, healthy attachments. We do see biologic disturbances, hyperarousal, sleep disturbances are very common in our kids, lots of nightmares, just anxiety about nighttime and sleep, difficulty controlling affect and behavior, so emotions and behaviors. A lot of times our kids are misdiagnosed as having bipolar disorder, which is actually not even a childhood disorder, but they still get labeled with that, and really they're just very trauma affected. But you do see these kind of like wild shiftings in emotion and mood that are related to the trauma, and it kind of looks like that maybe looks like what some people think is bipolar disorder. And we see lots of like poor self-esteem, a lot of disruptions in cognition, such as self-blame, guilt, shame, things of that nature. So here's just, some of the symptoms we see. Depression is actually really common. What is often surprising to folks, I think, is that even more commonly than PTSD, we see major depressive disorder in the aftermath of trauma, especially chronic trauma. And often we see the two together. They're very common comorbid conditions is what we talk about. So yeah, depression is, that hopelessness, helplessness. We see a lot of that, especially in the face of chronic trauma. But then we also see, and especially in our kids, and especially in our teenagers, we see a lot of these externalized symptoms. And let me tell you, like, I'm not being judgmental here at all when I say that these are what really get people's attention. And often we spend a lot of time talking about these things. And it's difficult for people to loop back and try and want to focus on like why we see these things. But I understand it because these things are not minor. Our kids they can act out for real in ways that are pretty severe. But what I would suggest to you is that many of those things on that externalized list, these are survival coping mechanisms for our kids. They've had to be tough. They've had to use substances to numb themselves. They've had to, manipulate situations for survival. And those are all hard habits to break, even when you're in a good and safe home, when that's all you've ever known. So it takes time, but understanding why they're doing those things, what's behind them, and what they need to feel like they can let go of those survival coping strategies is critical to really addressing them effectively. I won't go too deep into the whole PTSD thing other than to say that a lot of our kids are misdiagnosed because they present to us in settings where we don't have the background or the context to really understand why. And they do have these big behaviors and these big issues that you can't ignore. So that's part of it. But also post-traumatic stress disorder, like I told you, it's fairly new to us. We've only been thinking about how PTSD looks in kids for about 20 years, maybe a little less, honestly, like not that long. Like when I was in grad school, the first time for real, like nobody even talked about it in kids. And that was in the late 90s, early 2000s. So it's not that new. So the criteria that appear in the DSM-5, for those of you who are, know what I'm talking about there, the big like book that lists all the things that are wrong with all of us. That's written for adults. And there have been a few caveats added in the most recent edition, the DSM-5, that are like, if you're assessing children, then it might look like this, or if you're doing this with children, it might look like this. I'm part of an international group that has for years been trying to get them to write criteria just for kids, because PTSD because of developmental reasons, looks quite different in children than it does in adults. A 5-year-old is not going to be like, I think I'm having, some intrusive thoughts right now. Like, that's just not going to happen. But they might enact those intrusive thoughts in their play. So there's we need to have maybe more guidance, I think, for people on what to look for, because if you're not looking specifically or asking specifically, you may never know. A lot of these PTSD symptoms are very invisible. And what we say in kids too, because of all the developmental differences, is they don't need to meet full criteria. They need to be if they're experiencing a clinically significant symptom of post-traumatic stress, you need to treat them for that. These criteria, that maybe they'll meet some of them, maybe they'll meet all of them, but let me tell you, just even one clinically significant symptom of traumatic stress, it's a big deal. It's definitely, let's say you're only having flashbacks about the trauma that you've experienced. You would probably want someone to help you get over that. That's a lot, just that one symptom, but they're very rarely ever experiencing just one. It just doesn't meet the criteria set out for adults quite so neatly. But we see, even in spite of all that, in spite of the criteria not meeting them so well, in our high-risk populations, we see about triple the rate of PTSD we do in the general population. So general population stats for most mental health conditions, we see about 5 to 8% of the population could be diagnosed with major depressive disorder or PTSD. But in our child welfare populations, we see 15 to 20%. Sometimes we see 60% in the residential centers and things, but on average, we're seeing at least triple in juvenile justice, child welfare, any of these like kind of higher risk groups of kids. And why is this a big deal in the long term? I think you guys have probably heard about the ACEs study. Am I correct? I know this information is being distributed a lot more, and that makes me happy because it helps people understand how adversity and trauma in childhood is a problem in the short term, but if you let it be unaddressed, it can be a very serious problem in the long term. And here, this is from the work of Filiti and colleagues based on a Kaiser Permanente study that was done, I don't know, I'm terrible with time, maybe like 15, 20 years ago now, but anyway, basically what they found in a study of adults was that the more childhood trauma you had, the more likely you were to experience all these things. And one thing kind of led to the other. So if you have you experience a lot of child abuse when you're young, then of course it's going to disrupt those domains of functioning that we talked about, socially, emotionally, cognitively. Let's say you never get help for that. It continues. So you start using drugs and alcohol or acting out sexually as a way of kind of numbing and coping. The next thing you know, you're involved in juvenile justice. Then you get involved in criminal justice, you develop, a series of other social problems, and all of which make you more likely to experience disease, disability, and things that lead to early death. Like, they have actually done studies that show that like the number of traumas that you experience is literally correlated with years of life less that you're going to experience. And not just, and not just that, but like so many other serious things like suicide, substance abuse. And I don't mean like a little bit. If you've had 4 childhood traumas, then I think it's like 1,000 times more likely to use illicit drugs in your teenage and young adult years. It's a big risk. So we know that trauma is bad. I've convinced you now, right? We can all agree trauma is bad in the short term, but trauma is bad in the long term too. The good news is that we do actually know what to do about it. There's been a huge amount of growth in the clinical research arenas, certainly in how to treat trauma and traumatic stress in adults, but definitely in how to treat trauma and traumatic stress in children as well. It's a group effort, because really the number one thing that you have to do to treat trauma in kids is to make it stop, right? You could be the most brilliant therapist in the world in an outpatient clinic, but if that kid's going right back into the trauma every day, I mean, really, it's not going to do what you want it to do. So first and foremost, you have to help kids, adults, whomever be safe, and then we have to help them feel safe. And just because you've made it stop, don't think that they like suddenly are like, oh, I'm safe now. You know, it's not like that when you've been chronically victimized. And that's a step. I think even in my young clinician mind, I got that, okay, you know, I have to do at least a little bit of case management work here to make sure that these kids are safe so that I can do the kind of treatment that they need. But I didn't understand just how much effort needed to be made to help them feel safe once they were again. They're not just going to assume just because, oh, this is a really nice foster home you've taken me to, oh, I'm safe, I don't have to worry about my survival anymore. No, that's not really the case. So I think that's something that a lot of us in recent years have really been trying to do a better job of focusing on. So case conceptualization is important. I think I've tried to show a few of the ways that we kind of miss it. But if we can understand the why of the behaviors, we can really make some good progress. It'll give us good guidance on what we need to do next to help kids be safe, to help them feel safe, and then to give them the skills that they need to recover, because kids really actually are amazingly resilient. Adults are too. Adults can recover from this trauma too. I feel like the trauma recovery needs of our adult population in the child welfare system are greatly under acknowledged. There are a lot of adults, especially women, who are not yet safe themselves. And certainly don't feel safe. And even if they are in a more stable place, just in terms of situations, they're not being given the evidence-based trauma treatments that we actually do have available. So one thing I would like to posit is that it's really critical for us to understand if trauma is a factor for a kid. If we have any reason to suspect, i.e. they're at all involved in the child welfare system or juvenile justice, for example, then we need to get a trauma assessment and see, is that what's going on? And a trauma assessment is basically just like a regular mental health assessment, but you always include a review of the child's trauma history, and you specifically screen and assess for trauma symptoms. And again, if you don't ask, you might not know, because many of these are very internal. They're invisible. So you have to ask kids, and you could have like a kid who really is exhibiting no behavioral problems, but it's very much internalizing for them. And you really wouldn't know with those kids unless you ask. We do have a lot of standardized assessment measures that you can use. Now for kids and teenagers, you can have caregivers fill them out. For younger kids who aren't great reporters, there's lots of options to do this kind of assessment. And there are a number of evidence-based treatments available for the treatment of child traumatic stress for kids of all ages. I mean, a bunch of them, and they have robust support. And, you know, we use a few of them in our clinics. I do see kids, really tough kids who've been in and out of residential facilities. One of my last patients had 32 placements in his young life, 32. That's horrible. He was 15 when I started seeing him and had 32 placements. So, I mean, these are not kids with just a little bit of trauma. But if you do these evidence-based practices with them, with fidelity, we get them in a safe home, we get them a caregiver they can rely on and attach to and trust, they can recover. They do quite well. And I do see a lot of hopelessness around our adolescent populations, and I get it. I understand that these kids are pretty difficult by the time they come to a lot of folks' attention, but I don't know, I would challenge everyone in this room to think back to when you were 16 or 17. You're probably pretty different now than you were then, right? I know I am. So yeah, yes, it is harder to create change in that 15-year-old kid that I worked with who had 32 placements and had given up. I mean, he had been adopted through foster care, that failed. He didn't want to be adopted. He could do it on his own, but he was acting out and getting kicked out of every place he went. But he did get better. He is doing really well. I am happy to report it's not always easy. There is some back and forth, but Yes, that is a tougher scenario, I can't lie, than working with a 5-year-old who, yeah, did experience significant trauma, but, was quickly adopted, didn't experience all those secondary kinds of problems like multiple placement disruptions, more years of trauma. But I mean, for our young people too, our young adults, transition age youth, adolescents, there's a ton of hope there. It's a great opportunity. And every time I get a case that comes across my desk of a kid who's 15, 16, 17, even 18, 19, I think, oh yeah, it's now's the time. There's still a lot of hope there, and it's not to say it's hopeless when you're an adult, but again, it's just easier for kids to change. Our brains aren't even fully developed until we're 25. We used to think it was 18, but I don't know. Can you remember? I mean, some of you maybe like are 25. I don't know. Everybody looks so young to me anymore. But if you are beyond 25, think back to when you were 25. I think about this all the time. I was such a hot mess as a young person. Like I couldn't remember to pay my bills, and I couldn't remember. I don't know. I was just like developmentally delayed, we'll say. But I remember waking up at some point when I was about 25 and being like, you know what, I think I can do this. Like, I feel like I kind of got it together. Like, I've got a budget, I'm paying my bills. And so I don't know, it doesn't surprise me now that we realize your brain's not even fully developed until you're 25. Some people say it may be later for male brains, like because boys sometimes emotionally develop a little later, but I've not seen that actually proven. So we do have a bunch of good evidence-based practices. I'm not going to go deep on this, but across the study of all the things that work to treat traumatic stress in kids, there's some kind of core components that seem to hold true. And I think this is a really important way for people in the community, or for people certainly doing clinical service with kids who are impacted by trauma, to understand it. Like, if you're doing these core things, you're really going to make a big impact. Doing a good trauma assessment, understanding, is there traumatic stress? And if so, like, what kinds of symptoms are they struggling with? Making sure they're safe, making sure they feel safe, creating a safe enough relationship for them to talk to you and be engaged in the treatment. A lot of people give up at this point because, yes, trauma affected adolescents, that's a tough nut to crack right there. I'm not going to lie, but it can be done. And there's actual techniques that we use to do it. Usually I hear clinicians every day, well, he don't want to talk about it. Well, of course he don't want to talk about it. It's avoidance. That's a classic symptom of PTSD. And you're older than him and he doesn't think you're cool. So I don't know, like, you're just going to have to work at it. And we do have lots of strategies that can help us engage even those tough to engage adolescents, focusing on improving attachment and strengthening relationships. There are some core treatment interventions like reducing those distress symptoms, giving them more coping skills that can replace those survival coping skills that may have helped them in the moment but are not very functional now that they're out of danger. Paying attention to social context, and then processing the trauma. Almost, and I'm going to say there's actually a little bit of emerging research that says that there are some kids that do just as well with all these things and not directly really processing the trauma much. I would say for kids who've experienced chronic or complex trauma, they do need to process it for two main reasons. One, sometimes you don't know just how deeply disrupted some of their ways of thinking are until you get them to talk about it. Like, you may not realize just how much they blame themselves for their abuse, or how guilty they feel, or how ashamed they feel, until you really get them to tell their story. And you need to know that so that you can help them, let go of those things, because to hold on to that for a lifetime would really hurt them. And then I think, also for kids who've experienced a lot of trauma, especially at the hands of caregivers, mom, dad, boyfriends, or whatever, it makes them feel so disorganized when they think about their life and their place in it. And they don't know how to approach new relationships until they kind of work through some of that. So I think that's actually pretty important too. But some kids don't need it. It depends on their experiences. Yes.
When you say trauma processing, are you talking about in a professional setting?
Yes.
Or are you talking about just the supportive adults in their life?
Yes, that's a really good question, because I'm talking about, this is like what your trauma therapy should look like. These are core components of trauma therapy. But what you just said is important too. And that's something that happens and needs to happen also, which is kids. I mean, we should never, as important people in a trauma affected child's life, try to get them to process their trauma with us. If they need to do that, that should happen with a therapist. But will they talk to you about it? Yes. Do you need to be prepared to let them talk to you about it? Absolutely. That can be such an important part of their healing. And I train foster parents, that's part of my job at UK and at DCBS, on how to handle that when kids need to talk. If we shut them down in those moments, that can be really harmful to them and set them back in their recovery. If we say judgmental things about their parents, which maybe you might be justified in thinking or feeling, that might also be something that makes it more difficult for them. Like, knowing how to respond in that moment is really important, because they will talk once they feel safe with you, and they need you to be like validating and supportive when they do. It's a huge part of their healing. So if they can have a trauma therapist to process it with, and just like a safe sounding board to talk to about it too, hugely helpful. So I'm glad you brought that up. But these are core components of like the trauma therapy. Therapist self-care is a big piece, and you may have seen on there, on like some of our CTAC initiatives, that a big thing that we're interested in, and me personally as a researcher, I'm very interested in secondary traumatic stress and how that affects helping professionals. I've heard a lot of trauma stories over the years myself, and I've been affected by them, and never once in any of my educational experiences did anybody say to me, listen, you're going to be indirectly exposed to a lot of trauma. And, what's going to be hard about that for you? How are you going to deal with it? If it gets bad, how are you going to know? And when are you going to seek help, or what kind of plan are you going to have? That would have been quite helpful, because I think for a lot of us, you get out there in your first 2 years of practice, you're overwhelmed by some of the stuff you're exposed to, and you're like, oh, maybe I'm not cut out for this. Maybe I'm not tough enough. Like, what's wrong with me that I'm so upset by this case? Well, I mean, you're supposed to be upset by it. It's upsetting, but you do have to figure out how you're going to manage it, how you're going to, not let it affect your personal life. Although, work, people always talk about this work-life balance. Again, like there's some imaginary line. I mean, you carry yourself into all those situations, right? So that's a good thing, but you also need to have some awareness about what to do with that. So you're not alone if you've experienced that. That's pretty common, and we're realizing it's more and more common, and we're figuring out more things to do about that too. I'd be happy to come and talk about that topic someday if you're interested. But I'll leave you with this. This is just a listing of, these are kind of like the top, what is this? The top 7 most robustly supported, and I mean like randomized controlled trials, which is kind of our gold standard of evidence-based practices for the treatment of child traumatic stress. A couple of them have stars. PCIT has a star because it's a really big evidence-based practice for kids ages 2 to 7. It's been expanded to treat for up to 12-year-olds, and it's a really good program. It's really effective. It's not trauma focused per se, but it's been found to, because it's more behavioral and attachment based. So it treats a lot of the problems we see in trauma affected kids, but indirectly. But I will say it does have a lot of support for improving outcomes for trauma impacted kids, but it's not trauma focused. All these other ones are. The last one on there is one that we developed at the University of Kentucky in the Department of Psychiatry at CTAC, Jenny and I. And it's in the process of being beta tested. It's written, it's manualized. We're training clinicians on it. We're hoping to get more funding to roll it out and test it even further. But it does have some preliminary evidentiary support. That's why it also has a star. I just put a few notes here. Like, there's such a wide variety. I think when we talk about treating trauma therapy and evidence-based treatments for kids, we talk a lot about TFCBT, trauma-focused cognitive behavioral therapy. Amazing intervention. I mean, it really helps kids heal. I can't say enough about it. It's great. But it's not the only thing. And there's lots of things out there. You know, we do this CFTSI is one that we do, that top one. We were trained by the Yale Child Study Center, that they wrote this manual. And this one is for to be done with kids who've been exposed to trauma within the first 6 weeks of exposure to prevent the development of PTSD. I think that's so cool. And we've seen kids really benefit from that. So if you have a child who, you know, like the last case I had, it was some teenagers and they were in a car accident and one of them survived. And we saw that teenager, because obviously that's a kid who'd be very much at risk for developing PTSD from that terrible experience. And I think it was really helpful to him and his parents. You include caregivers. CPP, the next one, that's for really young kids. It's really 0 to 5, because a lot of times we're like, what do we do with these little ones? And guess what the average age of kids in child welfare is? 5. I mean, they're almost all, like 70% of kids in child welfare are in that 0 to 6 age range. So we need to have interventions for young kids. This is one that you work with the caregivers, because, you know, when they're that young, the way that kids cope with emotions and behaviors and recover is, you know, being co-regulated by a parent. So, you know, we're teaching them to create this therapeutic response environment for them. And then lastly, I'll just say about CBITS. This is another one that we've trained a bunch of schools to do. So we do see this in some of our schools throughout the state. And it's a group intervention and it's done at school. And it's, you know, it's nice. We have another intervention that was on the list called Target, that second one there, which I won't say all the words for that one. Like, oh, if I had to say all that every time I mentioned Target, you'd be like, oh, stop. But anyway, Target can be done in a group. So we do that in a group with our kids a lot, and they love it because they don't feel so alone. You know, I think a lot of them go through life feeling like it's just me. Nobody's been through this but me, but that's not the case, unfortunately. So this is just a little bit about our intervention. Again, we developed this largely thinking about what to do with these little kids. But again, it's working with caregivers and kind of creating very trauma-informed therapeutic foster parents or relative caregivers to kind of help co-regulate the symptoms that we're seeing in kids. But we do it with, you know, caregivers of very difficult teenagers as well, especially our teens who've been in and out of residential placement. That case I mentioned of my kiddo who had 32 placements and spent his last year and a half before coming to the adoptive home I worked with him in like a boot camp. So, I mean, he was very institutionalized is a word that people like to use for our kids. I did this with his caregiver, and we also did TFCBT with him. So he got all the things, and it really helped. It was not easy, but it definitely was a healing process for sure. And these are just like kind of the 4 key components of it: trauma awareness, using that caregiver relationship for healing, teaching like some, you know, hands-on kind of trauma-informed strategies to support the child's coping, and then creating that sense of safety that they need. And I think my colleague right before me gave this one away, but the best predictor of recovery and how we promote success and resiliency, like you were speaking about, Steve, was, you know, having that one secure attachment, that one person in your life that is there for you to keep you safe, that you can talk with, that can model how to cope with things, that can help you, you know, regulate your emotions when you get overwhelmed, etc. So we pay attention to that. We include caregivers in our treatment of kids that have been impacted by trauma. That's critical. They're always included. And I'll leave you with this. This is something we have in our trauma treatment clinic. We have these like big message boards all down the hallways. And so when kids complete treatment with us, we encourage them, if they want, to write a message to other kids who are just starting treatment with us. And these are some of the things that they say to each other, and it gives me chills every time I read them. I read them all the time, but I'm sappy like that. I'm proud to graduate because the things I've learned that I didn't cause the bad stuff in my past will help me always. Thanks for helping me talk about my past. I've learned how to be safe and not to feel so worried anymore. Please don't let your past determine your future. It's good to learn to control your thoughts and feelings. And then lastly, I love this one. Don't hold your past in, let it fly free, 11-year-old boy. So I think it's worth the effort. We want to create healthier adults. We want to create healthier kids, families. We have technology that's improving every day to help us do it. So any questions or thoughts? I don't know. I probably like took my time and everyone else's, but I get. Oh my gosh, you're like, not too terrible. Well, I'll tell you what, if anyone has a question or comment real quick, we'll take it and then I'll stop, but I'll give you my
We haven't
info.
talked much about the impact of social media on some of these challenges. In the last hour, Meta has been sued by 33 states, including Kentucky, over claims that youth's mental health is being endangered by social media. And when I see pictures of kids that are you know, second, third, fourth graders with technology in their hands doing these kind of things, and I hear about kids being bullied on social media.
Yeah.
I'm kind of glad that schools are beginning to look at let's collect all the phones and ban social media and phones and that kind of stuff from the school system, because I think that's really amplifying some of the challenges that you're dealing with over here.
Well, I think you're certainly correct. It does amplify the challenges. And I will just say, you know, the biggest thing about social media is that, and I hear this from my kids and families that I work with all the time, is that, you know, it used to be that if you were being bullied or having stresses at school, you would go home and it would end and you would get a break from it, right? A little bit, it would stop. But now there's less of a boundary because they're still in so much frequent contact with each other 24/7. And it is harder, I would say, more stressful environment and time for our kids. So, you know, trauma's not new, but yeah, it does create some new avenues for trauma exposure and less recovery time. So yeah, you're right. I'm gonna put you in charge of solving that one. All right, I'm gonna answer one quick question in the chat, and then I'm gonna go away forever, I promise. Do you have any resources for adults who have experienced trauma but have not, who never had that addressed? Yeah, there are a number of good treatments and, you know, good treatment providers. I think it's easier to find adult providers who treat trauma than child providers, still not much. But email me, my email was on there, and I can connect you if you wish. Thank you all. I appreciate it.